by recognizing our Senate Sergeants at Arms. Give us a wave, please. John Boyette, Keith Cannon, Michael Cavanis, Talika Cogdell, sorry, messed that last name up, Cherie Hedrick, and Chris Moore. So thank you all for being here. And let's recognize our Senate pages for this week. If you could come to that corner microphone and please tell us your name, your hometown, and your sponsor.
I'm Meyer Broad. I'm from Greensboro, North Carolina, and I was sponsored by Senator Garrett.
I'm AJ Fulton. I'm from Kings Mountain, and I was sponsored by Senator Alexander.
I'm Marion Hester. I'm from Candler, and I was sponsored by Senator Mayfield.
I'm Taylor Davies. I'm from Chapel Hill, and I was sponsored by Senator Meyer.
I'm Judy Gite. I'm from Greensboro, North Carolina, and I was sponsored by Senator Garrett.
I'm Jamison Clark. I'm from Raleigh, and I was sponsored by Senator Adcock.
My name is Drew Davis. I'm from Winston-Salem, and my sponsor is Senator Jones.
Lovely. Thank you so much for being here. I hope y'all are enjoying your week and that you will learn a lot of good things. Thank you. So we're going to get started with Senate Bill 171. Senator Bergen's going to present. While he comes forward, the Sergeants at Arms asked me to tell y'all that when the meeting is over, we need to clear the room promptly because there's going to be another meeting immediately following. So don't hang around. If you're going to hang around and talk, do it outside. So thank you. Senator Bergen, you're recognized to present Senate Bill 171.
Thank you, Madam Chairman. With your permission, I'd like to send forth an amendment, and after we deal with that, I can explain the amendment and the bill.
Thank you. So we have the amendment before the committee?
I think it is.
I believe it's on the dashboard. Okay, if you want to explain the amendment, please, Senator Bergen.
All right, this amendment language was worked on with the North Carolina Psychological Board and incorporates all revisions crafted and approved by them, ensuring that public safety standards are fully addressed. This exact policy passed the Senate Health unanimously last session twice. Master's level psychologists are the longest serving licensed master's level mental health providers in the state. They're the only master's level mental health providers regulated under the mental health boards that cannot practice independently after a period of supervision. All other master's level mental health providers are able to apply for independent licensing after a maximum of 2 years of supervision. They have a master's degree in psychology, have completed supervised training prior to graduation, and passed both the state and national psychological exam, the EPPP, to become licensed. They have practiced under the Psychological Board since 1967. This lifelong supervision has barred them from certain employment opportunities and from paneling with major insurance panels, causing them to have to turn down North Carolinians that they are trained and qualified to serve. Their restricted license even bars them from volunteering as mental health providers with organizations like the Red Cross, as seen with Aline. This impact to access has major impacts on our communities. For example, current wait lists for psychological assessments often exceed 8 months. Most facilities and programs like group homes and residential placements require a current psychological evaluation for admission, and many insurance providers also require a current psychological evaluation to cover some services. An 8-month wait list for services has a detrimental impact on the quality of care for individuals. Think of children at an 8-month delay to determine by assessment the issue that the child may have in order to provide them the care they desperately need has a massive impact on the child's development and quality of life. Because of this restriction on their license created by career-long supervision, master psychologists are turning away children and adults that desperately need the services that they're qualified and trained to provide. This bill will help address that. The Psychological Board saw this issue and attempted to create a pathway to independent practice themselves. They were blocked by the Rules Review Commission, which determined it would take a change in statute. That is why, that's what's brought us here. This provision will allow master's level psychologists to practice independently after 4,000 hours of supervision. That's at least 1,000 more hours of supervision than any other master's level mental health provider in the state. This does not lower licensing standards, create new titles, or expand scope of practice. Masters will continue to be regulated by the North Carolina Psychological Board and held to the same legal and ethical standards that have always governed their practice. This bill also restructures the nomination process to better reflect the professionals it represents. The entire nomination process here was rewritten and voted on by the Psychological Board. This policy is supported by Trillium, Health Resources, VIA, Daymark, Atrium, the North Carolina Association of Professional Psychologists, and Wake Forest School of Medicine. And I think a number of other members have gotten numerous letters of support, and I've got stacks of them, and I'll be happy to answer any questions, Madam Chairman.
Thank you, Senator Bergen. We have the amendment before us at this time. Is there any discussion on the amendment? If there's no discussion on the amendment, Senator Waddell.
Yes, I heard you mention those who were in support of it. Have you heard from those who work in schools, the school psychologists?
Senator Bergen.
I would have to go through the list and see exactly if there are some from schools. I have heard from some folks that are against it, and they are mostly the PhD folks, not from, but Senator, I can't say that I got anything from a school psychologist that was against it.
Senator Waddell?
Yes, I was concerned because when you mentioned the groups that were for it, and I want to make certain that they were covered too in this legislation if it was something that would be beneficial to them.
Madam Chair?
Senator Bergen?
I have to believe that, I know from talking to my school folks, they welcome a change like this because they have children that they cannot get assessed right now.
Thank you.
Senator Waddell, any further follow-up? Senator Mayfield, is this on for the amendment?
It is.
Okay, please go ahead.
Can you, so there are a number of changes in here. Can you tell us a little more specifically about the changes to the bill that are in the amendment versus the underlying bill? I mean, are these additions to, substitutions? Seems a little bit of both.
A little bit of both.
Okay.
Excuse me, Madam Chairman.
You have the floor.
It's a little bit of both. Some of it has to do with, as I said, the board. The majority of it, though, is just clarification. These folks will not be able to do anything that they're not already doing. It just has to do with some of the supervision. And I've actually had folks from this side that is not wanting to happen, and they've told me, they said, we don't really have any problem with this, but we want you to add this and this and this to it that just makes it more restrictive. And I think the telling thing is, everywhere I go, especially in rural North Carolina, people are telling me they cannot get kids assessed. And so that's I think the importance and why we're trying to get this bill moved and get these people that are qualified to do it. And hopefully this will be a good avenue for more people to look at North Carolina and say that they're going to come here and practice.
So Senator Bergen has made a motion to amend the bill. If there's no more discussion on the amendment, all in favor of the amendment, please say aye. Anyone opposed? Thank you. So the bill is before us. Is there any discussion on the bill itself? Senator Johnson.
Thank you, Madam Chair. Senator Bergen, thanks for bringing this bill. I've looked through the bill, and I just wanted to confirm with you, I don't see anything regarding payment parity, reimbursements, or anything. Is that accurate, that this does not have anything to do with payment?
Senator Bergen.
That is correct. This does not change payment at all.
Follow up.
Senator Berger, are you aware of any maybe future action? Have you heard anything about maybe wanting to come back for payment parity at a future date?
Senator Bergen.
No, sir, I've not.
Thank you. That's all.
Thank you. Senator Mayfield.
Thank you, Madam Chair. I'm aware that this bill doesn't address scope of practice, but either can you or maybe there's somebody in the audience who can talk about the difference in the scope of practice between a licensed clinical psychologist with a PhD and a master's level?
Senator Bergen?
Senator, with you and the chair's permission, we do have some speakers that will be coming forward, and I think they are the best equipped to address that.
Okay.
And so I could try, but I think they will do a much better job than me.
And follow up?
Follow up?
Thank you. And then will a master's level psychologist have to distinguish between, in their advertising or anywhere else, whether they are under supervision or not under supervision? How would a potential patient know?
Senator Bergen?
Madam Chair, I'm going to defer to staff and ask if that, I can't remember if that is spelled out in here, but either staff or we'll let one of the speakers, when they get up, they can, I think, address that.
I believe Stuart Starkey is equipped to answer questions on the bill.
Yes, Stuart Starkey, Legislative Analysis. The bill, as far as I've seen, it does not have anything regarding scope of practice.
Thank you. Follow up?
Follow up, yeah. So maybe somebody who's going to speak to us can answer that question about, notice to potential patients and the public about whether they're still under supervision or not. And then my final question is, how does this 4,000 hours of supervised time compare to other master's level professionals like other kinds of counselors? Is this more? Is this less? Is this comparable?
Senator Bergen?
It is more.
It's more.
Yes, ma'am.
Okay.
In fact, I think this is the most. I've seen others that are like 2,000 hours. I think this is the most.
Okay, thank you.
All right, other questions before we go to the speakers? Okay, so have Mr. Richard Roomer, if you would come to the microphone, please.
Good morning, Senators. I'm Dr. Richard Roomer here on behalf of the North Carolina Psychological Association. NCPA has long supported a thoughtful path to independent practice by master's level psychologists, and we are near that goal. SB 171 does not achieve that goal. In some ways, it creates more problems than it solves. When North Carolina first licensed psychologists in 1967, there were standards for training doctoral level psychologists, but not for master's level psychologists. To license master's level psychologists and improve public access, the law required them to practice under supervision. Master's level standards became available only in 2023. Building on the training standards, national guidelines for licensing master's level psychologists for independent practice came into place just a few weeks ago. That proposal is not what is before you today. SB 171 has several serious flaws. SB 171 does not distinguish between master's level practitioners who can practice independently and those still practicing under supervision. SB 171 does not propose a scope of practice for independent master's level psychologists that reflects their education, training, experience, and supervision. SB 171 does not incorporate the new national accreditation standards for education and training. The bill before you only addresses current licensed psychological associates. We need a bill that will deal with future master's level psychologist licensees and give all master's level psychologists a nationally recognized license. We're here with a draft bill that does that, but again, that's not SB 171. We urge you to hold this bill until we can meet with the other stakeholders and craft a bill that represents consensus. Thank you. Since I have 30 seconds and there have been questions about the bill, I would simply remind you that I was the clerk of the work group that drafted the major overhaul of this bill in 1991, and I'm available for questions. Thank you.
Good morning, Senators. I'm Dr. Mary Evers here, also on behalf of the North Carolina Psychological Association. While NCPA supports independent practice for master's level psychologists, we find it necessary to oppose SB 171. It's deeply flawed in its failure to provide a distinct title for independently practicing master's level psychologists. This continues to be a glaring omission especially after it was pointed out when this same bill was introduced during the last legislative session. Furthermore, it is now outdated by its failure to mention current accreditation standards for master's level training programs and its omission of a scope of practice in keeping with the newly available national guidelines developed by the Association of Boards of Professional Psychology, the association for all the licensing boards in the 50 states. This failure to adopt national guidelines will make it impossible for North Carolina to join any interstate compact for master's level psychologists that will exist in the future. This will limit mental health access for North Carolina citizens because they would not be able to access telehealth services for master's level psychologists in other states. It would also perpetuate the current problems that our LPAs have with license mobility. This is simply not fair to our citizens or our LPAs. Although you have not seen it, NCPA has a better bill ready today that is very close to SB 171 and addresses and improves on it. This bill has a scope of practice in keeping with national guidelines, includes a timeline to quickly allow independent practice for qualified LPAs who are currently practicing here, and gives them a distinct title, and includes the current accreditation standards for training programs to ensure that future master's level psychologists in North Carolina have high quality skills. We urge you to hold SB 171 so that more stakeholders can craft a bill with wide support among North Carolina psychologists. Thank you.
Carol Williams.
Good morning. Thank you, Madam Chair and committee members. My name is Carol Williams. I'm a master's level psychologist and I'm a behavior analyst doctoral. I'm here to speak in support of SB 171 as a psychologist and the co-president of North Carolina Association of Professional Psychologists. To be clear, the North Carolina Practice Act does differentiate between master's level and doctoral level psychologists. And in terms of differentiating between supervision, I myself include in my start of care contracts that I am under supervision, and that information is available if you were to verify a license, for example, on the North Carolina Psychology Board website. So those are absolutely in statute and in practice as we speak. As for scope of practice, we have always had the same scope of practice. There's no limitations on that, and we're not asking for any changes to that. Myself, I have to turn away individuals. I turned away 3 people just in the last week because of the restriction on my license, because I can't get contracted with some of the major insurance providers in the state. And that is strictly and only because of the supervision that is for my entire career. And ironically, I can supervise other master's level psychologists, which I do. So the supervision is not in reference to competency or anything of that nature. It's an outdated rule that prohibits care for our citizens in the North Carolina and restricts us from providing services. I thank you very much for your time. I am very welcome to any questions that you might have. I'm well versed in this issue. I've been working on it for years. Thank you very much, and thank you, Madam Chair, committee members.
Vinston Goldman.
Good morning, everyone. My name is Vinston Jerome Goldman, a resident of Durham County. Thank you, Madam Chairperson and Health Committee members, for the opportunity to speak to you today in my support of Senate Bill 171. I'm a retired tenured associate professor after 35 years as a faculty member in the Department of Psychology at North Carolina Central University. I served as the coordinator of Central's Master's Level Psychology graduate program for 24 years. I've had the honor to help train professionals who provide, as master's psychologists, much-needed direct care services to the people of our state. Members of those students are here today. History speaks to the fact that master's level psychologists have been a bedrock for mental health service delivery within North Carolina, particularly in state institutions or agencies. SB 171 reflects competent and safe practice, and it addresses the need for access to more psychological services providers for our citizens, especially in rural areas. and enhances fairness and regulation compared to other master's level practitioners. I strongly believe that not only is allowing practice by LPAs in accord with SB 171 the practical thing to do in regard to increasing accessibility to mental health services in our great state, it is also the ethical thing to do. Also, we have had people practicing for a long, long time. The issue before us, the main issue, is whether or not those people who demonstrated the capacity to practice well to continue doing that. We have been delaying this for a long time. I am grateful and thankful to you for the opportunity to speak today and for your service to our state. I respectfully request your support of SB 171. Have a great rest of your day.
So that was our last public speaker. Pursuant to the public speakers, is there any more discussion or debate on the bill? Seeing none, Senator Sari has made a motion for a favorable, I'm sorry.
Madam Chair.
Oh, I'm sorry.
Thank you.
I did not see you. Senator Applewhite's recognized.
Yes, ma'am. I'd like to ask the bill sponsor a question.
Senator Bergen?
Yes, ma'am.
Thank you, Senator Bergen. As you all know, this is my first time on Healthcare Committee, so I don't have the knowledge of what happened during the last session. But the first two speakers mentioned that they have drafts of bills that, would make this effort more agreeable. Have you had the opportunity to read that draft? Have they collaborated with you at all to ask your opinion of it?
Senator Bergen?
Thank you, ma'am. That's a great question. I have met with them numerous times I think I've been working on this for 4 years, and every time it was, we want you to wait. So when they came and said that we have a draft now, I have not seen the new draft. I've seen some things they wanted me to add to a bill, but it was more, they say we don't have a problem with what the master's level folks are doing now, but we want you to do this and this and this. And what I saw was just more like a turf war. We have the PhDs that are wanting a certain thing, but then the master's level folks who are out here doing the work and all of that, they're trying to make sure that these people get seen. So I'm always happy to look at stuff. I'll be happy to meet with them if they've got the new language that they have. Be happy to look at that, and then as we go down the road, if we need to add some things, be happy to do that. But I know that there are people, especially kids, that are not being seen. I've been to all of our mental health facilities. I've toured Secretary Kinsley when he was secretary. We had 14 town halls across this state, and everywhere I went, it was, we cannot get children assessed. Dr. Shahid was here last week. I think some of you met him, that he was here. He at ECU, he's the gentleman that put in telepsychiatry in the majority of the hospitals across this state, over 79 hospitals. He's been working on it for years and years. He would have been here today to support this, but he's having eye surgery this morning. And so, he's in support of it. A lot of folks are in support of it. I know today there's probably 50 to 60 kids that are in emergency rooms, involuntarily committed, that somebody needs to see and talk to. So I'm just very concerned about it, and I think we need to go ahead and move this. Be happy. I've always told everybody, I have an open door policy. I'll talk to anybody about anything, but we need to move on and start getting this taken care of. Thank you.
Follow up, Madam Chair.
Follow up. We have 2 more bills to do, and we're 25 minutes into the hour. So how about last follow up? Thanks.
Yes, ma'am. Senator Bergen, do we have an estimate of the number of additional practitioners to meet the needs of our children that would be available if this bill passes?
Senator Bergen?
I do not have that number, but I will get you that number.
Thank you, sir.
Thank you. So Senator Sari has made a motion for a favorable report for the bill as amended, rolled into a new PCS, unfavorable to the original with the referral to rules. All in favor, please say aye. All opposed? The ayes have it, and that motion carries. So now we'll call forward Senator Sari to present Senate Bill 335. And I believe there is an amendment.
Thank you, Madam Chair. There is an amendment. I'll go ahead and send forth my amendment so we can talk about the bill as amended.
I believe
Amendment ABC-16 V7.
I believe the members have the amendment before them, and it's on the dashboard. Senator Sari is recognized to present the amendment.
Thank you, Madam Chair. So the bill before you today is a test and treat bill with respect to flu. The amendment expands the test and treat components to flu and strep throat as well. It also provides some guardrails in place after hearing feedback from some of the stakeholders with respect to developing rules and protocols by the Pharmacy Board and the North Carolina Medical Board, and I would appreciate your consideration and support.
Any questions on the amendment? Senator Adcock.
Thank you so much. Senator, sorry, so this doesn't change anything substantive about the bill, though. Is that right?
Senator Sari.
Senator Adcock, I would probably suggest it does have some changes worth discussing. So the original bill as filed only addresses flu. So this expands it to also address strep throat as well. The original bill as filed does not provide the rulemaking provisions with respect to the Pharmacy Board, the Medical Board, and the State Health Director. Some of the feedback we received was who's going to help develop and implement some of these protocols in place, and have some audit enforcement mechanisms with respect to the dispensing. So this bill, this amendment does address that.
Sounds like it really enhances it. Thank you very much.
Any other questions or concerns on the amendment? Seeing none, Senator Johnson has made a motion to amend the bill. All in favor, please say aye. Anyone opposed? So the bill is before us as amended. Senator Sari is recognized to continue with his explanation.
Thank you, Madam Chair. Every year between 600,000 and 1 million North Carolinians suffer from flu. This past year, I believe the most recent data showed that we had over 300 people that passed away in our state. Flu is easy to treat. Strep throat is also relatively easy to treat. We have a standard course of medication for both that's readily available at your pharmacy and can be given. However, that medication generally requires a prescription. This means going to the doctor or an urgent care to receive a test to determine if you've tested positive for either. We can save costs and time while delivering great patient outcomes with this particular piece of legislation. The average wait time to see a family physician in the United States is about 20 days. And even if you're able to get that immediate appointment at the doctor or the urgent care, that still means an extra trip to the pharmacy to obtain the medication that's actually going to make the difference in your virus or disease. This bill cuts out that time and gives you direct access to a retail or community pharmacy. It's using testing that's proven with a low error rate and used consistently in our point of care context. It gives our retail pharmacists the ability to further expand upon what we asked them to do during the COVID era with respect to their testing capabilities. We heard some concerns as we talked about in the amendments with respect to the protocol. So who's going to develop some of the guardrails and rules in place with respect to the course of treatment and what's required. We have listened to that, and we've put a rulemaking ability in place with the Pharmacy Board, the Medical Board, and the State Health Director. We also are looking at ways that we can further enhance this with certain other categories of patient populations and potentially other diseases that might have the ability for similar CLIA testing capabilities. This bill is about access, cost savings, and care, especially in our rural communities like in Johnston County, where a Main Street pharmacy is oftentimes the healthcare providers that people can most easily reach. I appreciate your consideration. Ask for your support.
Thank you, Senator Sari. Senator Corbin.
Thank you, Madam Chair. Thank you, chairs, for bringing this bill to us. And I support this bill sponsors, and it is access to care, very important in rural North Carolina, which I represent. And at the appropriate time, I make a motion for favorable report.
Thank you, Senator Corbin. Anyone else have a question or comment? Senator Adcock.
Thank you so much. I agree 100%, Senator Corbin. It's good to see all these bills about increasing access to care on our agenda every day, but particularly today. I'd point out a couple of things. Number one, it's really good that you added strep to this bill, because while flu is seasonal, strep is ubiquitous. And so more people are going to be affected by that at any given time, particularly in the non-flu times. We talk a lot about treatment, which is great. The testing for this, these CLIA wave tests, are tests people can do in their homes. So they're extremely safe with a low error rate, as you have pointed out. And so this bill has everything to commend it, and I look forward to voting for it. Thank you.
Thank you, Senator Adcock. We have public comment. We have Penny Shelton signed up.
Good morning. Hi, I'm Penny Shelton. I'm the Executive Director for the North Carolina Association of Pharmacists. Madam Chairman, I appreciate your leadership today. Also want to thank Senator Sari, Senator Galey, and Senator Bergen for your primary sponsorship on this bill. And also want to thank the members of the Health Committee for your support in getting this bill to this point. This has been a long time coming. The pharmacists in our state have been greatly underutilized in the areas of public health. And I want to mention that there's been some discussion this morning that's been brought forth by Senator Sari about the use of protocols. If we look across the United States, the vast majority of our states have some form of test and treat, either through standard of care, full practice authority, or through the use of protocols. In our own state, for hormonal contraceptive care, as well as tobacco cessation care, which the General Assembly passed a couple of years ago in 2021 under the leadership of Senator Bergen. We have put together protocols. These protocols are very strong. It's been proven in every state that is using protocols that the care for flu and strep can be done very safely. And so I applaud this group for bringing forth this legislation. We're very grateful. We look forward as pharmacists in this state to being able to help address these conditions that if they are not treated earlier, people spread it, and that's part of the issue that we're dealing with. We want to provide faster access to care, and we want to be able to help keep patients from getting sicker and ending up in urgent care and in our emergency rooms. Emergency rooms this year were completely overwhelmed with flu cases. And if we had this type of ability in place this past flu season, we would have been able to prevent a lot of those cases and some of those deaths even. Thank you very much.
Thank you. Senator Corbin has made a motion for a favorable report for the bill as amended, rolled into a new PCS, unfavorable to the original with a referral to rules. All in favor of the motion, please say aye. Aye. Anyone opposed? Motion carries. Thank you. Next on our agenda, we have Senate Bill 370, and Senator Sari is recognized to explain the bill.
Thank you, Madam Chair. We saved the least controversial bill for last, and I appreciate you doing that. Senate Bill 370, otherwise known as Repeal Certificate of Need laws. Before I go into some of the discussion, I want to thank Senator Hayes for his previous leadership on this topic. I know it's something he's been passionate about for a long period of time, and we've made small steps and look forward to continue to work with you on that. Certificate of Need has its origins going back in North Carolina nearly 60 years. In the 1960s, there was a movement that was made around this country with respect to the allocation of healthcare services and facilities with respect to scarce federal dollars. Our first CON provision was enacted in 1971 in North Carolina, and that law was short-lived. And I think the history is important just because it probably provides some context for this debate. 2.5 years later, in 1973, in a case called Aston Park, it was a hospital. Those laws were subsequently declared unconstitutional on anti-competitive and anti-monopoly grounds. And there's some language in the North Carolina Constitution about constitution and monopolies that I would encourage everybody to read at some point after this committee meeting. But that decision was short-lived because in 1978, federal law changed with respect to the allocation of dollars. As we so often see at state government, what happens at the federal level trickles down, and they have the power of the purse, and we're compelled to go along and get along in order to attain that. So we passed a second set of CO laws in 1978, and that law was called the National Health Planning and Resources Development Act, which required a development of some type of certificate of need plan. What that federal law did was it talked about allocation of resources and required the CON system in order to have access to those federal funds. But that federal law also was short-lived. There's some changes that were made in the early 1980s with respect to the Medicare and Medicaid fee-for-service model. So in 1986, Congress repealed the National Health Planning and Resources Development Act. But what didn't happen is North Carolina did not repeal its CON laws, and those stayed in place. And since that time, there's been a general recognition that certificate of need with respect to facilities, equipment, and processes is anti-competitive. We've had this conversation. It's almost an evergreen conversation that comes up in the context of the North Carolina General Assembly. They're free market groups. I'm sure we'll hear from some today, and I'm sure some of you have heard from those members, leading up to this committee meeting that talk about the central planned nature of going through the state medical facilities health plan is antithetical to what we value in North Carolina with the free market system. In a lot of times, in a lot of ways, the reason the CON system was set up back in the 1970s is failing and no longer applicable in 2025 in a state with 10 million plus people and growing faster than anywhere else in the country. Federal actors have also talked about our CON laws and how they're failing at controlling costs and controlling access to care. In an article in 2015, an FTC commissioner wrote, "We know that these laws, CON laws, are actually restrictions on output, and output restrictions restrain the social benefits of free market competition. And among those lost benefits is the pressure to reduce prices and innovate. Ironically, a government program originally aimed at reducing healthcare prices is likely inflating them, at least in some situations." And the author concluded by saying that competition lowers prices, improves quality, and inefficient or inferior healthcare services should lose business to better rivals. Government regulation that undermines the socially beneficial competitive process without returning any offsetting benefits simply cannot be justified. For those who have kept up this debate have seen that South Carolina has recently made major reforms to its CON. And in 2016, the FTC sent an article to Governor Nikki Haley. And the article included that CON laws create barriers to entry and expansion, which may suppress more cost-effective, innovative, and higher quality healthcare options. They concluded the CON process may be exploited by competitors seeking to protect their revenues and may facilitate anti-competitive agreements. And they concluded that CON laws generally appear to have failed to control cost. North Carolina is one of the most heavily regulated states in the nation with respect to certificates of need. We have more regulations and burdens in place than just about anywhere in this country. And we've seen the peculiarity of our CON laws play out in this chamber. Just last session, I believe everybody in this room was on the Healthcare Committee remembers that we had to pass an act of the General Assembly to restore behavioral health beds at a closed operating facility. Think about that. We had to pass a law so that somebody could fill a need. The state was not nimble enough at the administrative level in order to do so. We're seeing that peculiarity play out here locally in the Wake County market. One of the fastest growing places in the nation, we have a major health system with thousands of patients, thousands of oncology patients, and they have to fight and litigate and go through the process in order to obtain a certificate of need for the machinery they're sitting here today. And just yesterday, we saw a settlement in place between two of our major healthcare systems with respect to building a hospital system just to the west of us. And again, that could have been done without the need for litigation, consultants, costly analysts, in a state centralized economy, making the case they should or should not have that. It is time that we move past this, and it's time that we have a conversation about what this marketplace needs to look like in 2025 and going forward. I understand that we've heard from lots of stakeholders. In fact, as I was sitting here at the chamber today, I was getting tweeted at by, I believe, the Hospital Association. I don't see any of the hospital folks in here earlier, but I get notifications on my phone, and I smiled a little bit seeing that. I'm sure all of you, I saw a letter that came out yesterday from the Hospital Association, and I understand that's their position, and I understand that that's a very entrenched view they have to have. But everybody on this committee and everybody in the room that's in the healthcare place, I would challenge you to go back home and talk to your hospital president or your CEOs. There are major medical systems whose presidents and leadership are not opposing CON repeal. There are members that are actively advocating for a repeal of certificate of need laws because they see how burdensome and ridiculous it can be. In my own community, Johnston County, which is one of the fastest growing places in the state, much less the nation, the state medical facilities plan has struggled to keep up with the demand and find that we do not need more beds in our hospital system, but for having to go and fight and litigate and seek review of their determinations. As a final note, I'm challenging the stakeholders to come to the table and to discuss certificate of need and how it applies in your particular space. I support the free market principles, but also understand that you're operating in an already heavily regulated place with state and federal laws in place. Federal, state, and law with respect to skilled nursing facilities is different than similar regulations for ambulatory surgical centers. And there's a possibility that the North Carolina courts force this issue again, much like they did in 1973 with the Aston Park case. I think we can be proactive about this decision, but it requires a willingness to have that discussion rather than fall back time and again on the same entrenched positions that don't work, don't control costs, and don't let innovation occur in North Carolina's healthcare space. And I appreciate your consideration.
Any questions for Senator Sari? Senator Heiss.
Ma'am, I just wanted to thank Senator Sari and all the chairs here for continuing this fight against this unconstitutional practice in the state of North Carolina. I feel bright that regardless of the outcome, the sun sets in less than 3 years on these CON laws once it works its way through the courts. But we can save ourselves a lot of heartache and others walking through that legal process by passing this bill today. It makes no sense to me that a government committee controls an entire industry and who can expand and how they can expand, and the almost comical stories of trying to figure out when a mobile MRI became involved, how that disrupted their entire process because they couldn't figure out how to account for something that could move between facilities. This is coming in, and I remember all that we went through. I'm glad to see that this is sunsetting, and I would be honored at the time to move for favorable report for the bill.
Thank you, Senator Bergen.
Thank you, Madam Chairman. Senator Sari, thank you that was a great presentation. And just a statement. I served on the hospital board for 15 years, and I know Senator Heiss and I both served on the SHIC. I don't know if any other Senator Adcock served on it. So, which is the group that reviews the CONs. And what I found in my time on there, that it took on minimum 2 years and $500,000 to go through the process. And that a lot of the appeals were all just blocking mechanisms to keep someone from doing something. And the ones that finally made it through appeal, over 93, 94% of the CONs eventually got approved, but after millions of dollars and lawsuits. And I went through the process with Harnett Health in Harnett County to get a linear accelerator. We could not do any cancer treatments in Harnett County up until this past year. But we went through the CON process in the years, but it took 6 years from really 8 if you add the work up to it, from the time we started talking about it, got the CON approved, eventually built the building, and the linear accelerator is open and working, and now people are getting treatments in Harnett County, not having to drive to UNC or Duke or somewhere else to get those treatments. So, this has long been overdue. Senator Heiss, you and I have talked about this for years and years, and you were right back then, and you're right now. We need to deal with this. Thank you.
I'm going to go ahead and go to public comment while we still have time. Tim Rogers.
Thank you, Madam Chairwoman and Senators. Good morning. My name is Tim Rogers, President and CEO of the Association for Home and Hospice Care of North Carolina, and I've been in this industry 32 years. Our association represents 98% of the state's home health and hospice agencies, and I'm here today to speak just about home health and hospice and how we believe CON law plays a vital role in ensuring the integrity, quality, and accessibility of this vital service, and how we think it should remain in place. The CON process helps prevent fraud, waste, and abuse by ensuring that new providers entering into North Carolina meet rigorous regulatory and financial standards before entering the market. This screening reduces the risk of bad actors, exploiting Medicare and Medicaid, safeguarding taxpayer dollars while ethical business practices are held. I give you an example of the 4 states of Arizona, California, Nevada, and Texas that caused the federal government this year to enact a law bipartisanly supported to put a moratorium on hospice because of the proliferation of hospices in non-CON states and rapid fraud and abuse. In Harris County, Texas, in Houston, for home health, there are more home health agencies serving Harris County than the states of Virginia, North Carolina, South Carolina, Tennessee, and Georgia combined. And I just asked you that the quality of care is in the SHIC and the state medical facilities plan. And we also have something called special needs. For home health and hospice, that's very important. That's an exception. That allows new people to come in and prove innovation, something outside of proving need. I know that firsthand because I helped write it in 1995 for underserved populations, for Alzheimer's, dementia, and for other people in rural underserved communities. So it's not just need-based, it also means you can have an exception to the rule. So for home health and hospice, I ask you to consider this very seriously. We support it. Thank you for your attention to this matter. Thank you.
Dalton Clark.
Thank you. I've fought through a sea of leather chairs to be here today, so I appreciate you giving us some time this afternoon. Senator Sawyer got me fired up this morning. He took a lot of my talking points, unfortunately. I guess we're reading the same history books, but I will pick back up from 1986. Since 1986, every presidential administration has called for the repeal or certificate of need laws, from Reagan to President Trump's administrations and everyone in between. I'd really challenge anyone to find another topic that you could get every one of those administrations to agree on outside of certificate of need laws. North Carolina has more healthcare facility services regulated under CON than 48 other states. So we're the 49th most regulated certificate of need state. For a total of 27 certificate of need requirements. These regulations cover a vast range of medical resources, from complex open heart surgery to simply adding more beds to a hospital. According to the Mercatus Center, North Carolinians would save an average of $213 a year on healthcare spending in the absence of certificate of need laws. The researchers estimate that North Carolina residents would also benefit from a 5.8% decrease in post-surgery complications and would rate their experiences at hospitals at 4.5% more favorably. Listen, guys, in 2022, we put together a study, our friends over at Americans for Prosperity Foundation, that found that in a 10-year stretch from 2012 to 2022, $1.8 billion had been denied in CON application. I called them when I saw this bill was put before us. I said, can you find me what the new number is from 2022 to 2025? So from the end of 2022 to 2025, there have been almost $3 billion in denied applications. Almost has doubled in a third of the time. Time to end the CON. Thank you guys for your time. Thank you.
Cody Hand.
Good morning, Madam Chair. Good morning, committee. My name is Cody Hand. Thank you for the opportunity to be here. I'm here on behalf of the North Carolina Radiation Oncology Society, the users of those line acts you all talked about today. We oppose this bill, and specifically 4 line acts, linear accelerators. They're not just another piece of medical equipment. They're highly specialized, extremely powerful machines that use concentrated radiation to treat cancer. These devices emit ionizing radiation, classified as nuclear technologies. As such, they require strict safety protocols that in this state don't exist outside of the CON process. They require trained professionals, significant regulatory oversight to protect the patients, the healthcare workers, and the communities around the sites of these line acts. Operating a linear accelerator is a team approach. Each treatment requires multiple specialized staff who are already scarce in this state. This will become exponentially harder if there's a proliferation of underutilized linear accelerators needing these services, drawing them away from established and inherently more efficient locations. The CON process serves as a critical checkpoint in both the safety and the staffing, not necessarily for cost control and not necessarily for planning, but for safety and accountability. Removing CON for linear accelerators opens the door to inappropriate siting, duplication of services, and a breakdown in the coordination of oncology care. Cancer treatment isn't about convenience or competition. It's about precision expertise, and safety, we cannot treat these nuclear-grade medical technologies like any other. We have to have a process to protect our lives, and in the case of linear accelerators, this protection is absolutely essential. Thank you.
Thank you. So, as I mentioned at the beginning of the meeting, there is a meeting immediately following this one, and the sergeants at arms have asked us to clear out promptly. So I'm going to go ahead and call for a vote. Senator Heiss has made a motion for a favorable report for the bill with referral to rules.
Madam Chair.
All in favor, please say aye. Anyone opposed?
Madam Chair, I believe Senator Adcock and even
The
myself.
ayes have it, and we're out of time. We have to clear the room to get ready for the next meeting. I'm sure that we'll be able to ask more questions in rules.